Hello, and welcome to the 2022 GACD Masterclass. My name is JD Smith. I'm an associate professor at the Department of Population Health Sciences at the Spencer Fox Eccles School of Medicine at the University of Utah. Thanks for joining today. Today, I'm going to be talking about developing an implementation research logic model for the use in the design and execution of scale-up studies in implementation research. So the objectives today are to learn the fundamentals of the implementation research logic model, understand the basic goals of research to scale up effective clinical and health interventions, and then to explore using the IRLM for studies of scale up. And in this part of the lecture, I will talk a little bit about a scale up extension of the IRLM, a way that integrates other implementation research frameworks for scale up research with the IRLM. And then I'll provide a hypothetical case example. So to get started, let's talk about some foundations of the IRLM. This is considered a tool to integrate the necessary conceptual elements of implementation research. And this often involves multiple models, frameworks, and theories that have to be put together in a way that can convey your research ideas, potentially the study that you're going to be conducting, to yourself and to other readers and reviewers. The idea and intent behind the IRLM was to improve the specification of the phenomena in implementation research, which we know is necessary to inform our understanding of how implementation strategies work, for whom they work, and under what determinant conditions, and also on what implementation and clinical outcomes. The IRLM is grounded in a generalized theory of implementation research, which essentially proposes that implementation determinants help us to determine what strategies we will use to overcome those barriers and facilitators in the context we're implementing, that those strategies work through specific mechanisms of action to then exert their influence on most proximally the implementation outcomes, and then ultimately downstream clinical and health outcomes at the patient level. So why should I use the IRLM, you might be asking? Can't I just use CFIR or REAIM? I've heard of those. They seem great, and everyone else seems to use them. Well, they are really good models, and you'll see as we go through the IRLM that both of which are actually integrated into the IRLM. And one thing that's a little bit challenging is that currently there is no single theoretical model or conceptual model or framework that really actually does everything you need in implementation research. So it's really common to use multiple models and frameworks for different purposes. We have process models, we have determinants frameworks, we have evaluation frameworks, and we have theoretical models and just general theory. For a good overview of this work, the author Per Nilsson published a paper in 2015 in Implementation Science that really goes through these different kinds of frameworks and what their purposes are. So the IRLM combines multiple models and frameworks. You'll still have to name the models and frameworks that you use as part of the IRLM, but the IRLM itself is essentially a structure to help put those things together in a way that presents a logical process for implementation science. This model is supposed to facilitate the specification of the relationship between those multiple models and frameworks, and also includes implementation strategies. We do have compilations and other kind of taxonomies of implementation strategies, but these are really the independent variables and the things that we are going to introduce to try to make change. So they currently aren't presented as part of a framework in most situations. And what this really does, the IRLM is going to give the reader a snapshot of the many elements and their known or hypothesized relationships that are driving the implementation research project that you'll be conducting. You will still most likely need to use another framework or model, depending on the nature of your project. The implementation research logic model was not designed specifically to specify the process of implementation. And so process models are commonly still used as an external model for actually what's going to happen at what time over the life of a study. So that's a common addition. So there's multiple things that you can do to use the implementation research logic model at different parts and stages of studies. These are gone into in detail in the paper that we published in 2020. But right now, I'm just going to give a very brief overview. So implementation research logic model can be used when planning an implementation project. And this has probably been the most common use so far in the about year and a half that it's been published and available for consumption. We recommend that when you are using it for planning, that you work with your community partners and or the organization stakeholders that you'll be working with to help fill in especially the implementation strategies, but stakeholders can also be really helpful in identifying their priority implementation outcomes, potentially their priority clinical outcomes, as well as understanding the context. So being able to rate implementation determinants and potentially some other aspects that you'll see are part of the IRLM. In the planning stage, you often begin with the known parameters of a study and then work your way towards a full completion of the model. So often the known parameters are, we know what kind of intervention we might want to implement, whether that's a health promotion intervention, a preventive intervention, a treatment, or a public health intervention. We might know what we're going to implement. We often know too what the context is. And we also know sometimes what our primary outcomes we would like to achieve are. And in that particular situation, that means that you'll be focusing mostly on then figuring out the implementation strategies, the implementation strategy mechanisms, and potentially just fleshing out other aspects of the IRLM. When you're actually going to execute an implementation project, a completed IRLM can serve as essentially a protocol, and it can form the basis for ongoing tracking of what occurs, what has been altered from what was planned, as well as potentially unplanned deviations from the implementation. The IRLM has also been used retrospectively as well as prospectively to report what happened during the study. This often is in the form of a figure within a manuscript or a presentation that really gives readers an understanding quickly of what you found and all the different components of your implementation research project. So it helps you report the hypothesized relationships that you observed and things that may have actually been tested as well. It really helps facilitate the communication of your findings to an audience that would probably be unfamiliar with the project before that. And hopefully that will come through as we see some examples. One place that we envision the IRLM to be able to be used, but I'm not aware of examples at this time, is for the use of synthesis. So this is really the case of taking multiple studies on similar contexts or similar evidence-based programs or practices and trying to combine the findings of those multiple projects into a kind of shareable IRLM that can be generalized to a guide for future research and implementation. And this actually is potentially a place where going to scale or a scale-up context really could be helpful, is pulling from lots of different studies that have done similar projects and they're really drawing conclusions from their findings. So right now I'll give you kind of just some examples of kind of the standard implementation research logic model and then some basic variations before jumping into our scale-up example that I'm calling an extension. So in all of our IRLMs, the left-hand side is really kind of starting with determinants. So in this particular case, we use the terminology from CIFAR. So we have the process variables, characteristics of individuals, outer setting, inner setting, and intervention characteristics. We use the CIFAR as an example purely because it's quite familiar to folks. However, there are a number of other determinant frameworks that can be used in place of CIFAR in this model, and please feel free to do so. Some would include the theoretical domains framework, PRISM, that is associated with REAIM, and there are others like the EPIS framework does include determinants as well in the inner and outer setting, as well as bridging factors. So those could be included in this box. Following our generalized theory of implementation research, we then have our specification of our implementation strategies, which are connected to those barriers and facilitators that we'll be leveraging or trying to overcome. We then have the mechanisms through which those strategies operate to affect the implementation, service, and clinical patient outcomes. Those who are really familiar with implementation research might recognize that this outcomes box on the far right is actually a Nola Proctor and colleagues 2011 framework of implementation outcomes flipped on its side. So we borrowed heavily from existing theories, models, and frameworks, so the things were familiar to the reader and the user of the IRLM. A variation that you can do for different kinds of study designs would include using the IRLM to specify a comparative implementation project. So comparative implementation essentially tries to test two different implementation strategies or multi-component implementation strategy bundles or packages, usually in kind of a head-to-head or a two-arm implementation trial. So in this case, quite simply, you may specify, here are the implementation strategies that comprise strategy condition 1 or arm 1 in a randomized trial versus those in strategy condition 2. And in this particular case, the independent variable in this study design is the implementation strategy packages. And so really demonstrating the difference between those two will help demonstrate both the theory behind why one might be superior to the other, but also help interpret the findings. The most common implementation research logic model that we have found people using these days is a variation that we did include in the paper, but was not the central option. And this is one that includes the clinical intervention or the health promotion or public health intervention. So in this case, we just specify it here within the model. And you can see that this is demonstrating sort of a slightly grayed out or transparent arrow showing that the clinical intervention does have direct relationship to the clinical and patient outcomes. However, the full picture of an implementation project is really that intervention being selected because it's aligned with the context that's going to be implemented. Implementation strategies are selected both because they match with the barriers and facilitators and because they match with the needs of the clinical intervention, and that the full program implementation is going to occur through this full loop that gets us all the way through strategies, mechanisms, implementation outcomes, service, and clinical outcomes as our kind of ultimate downstream effect. We have had a couple of different folks that have tried to use the model who had a difficult time disentangling the mechanisms that were associated with implementation strategies and the mechanisms of the clinical intervention. So we created another variation here where those were split as well. So we have the ability to specify both the strategy mechanisms and the intervention mechanisms. And this was really helpful in planning that particular study. But again, you see the direct pathway here for how the intervention operates versus how the implementation strategies operate to get through implementation and clinical outcomes. So I'll give an IRLM example that is using the traditional approach, not yet into the scale up. So in all situations, there are a number of principles of use for the IRLM that we want to stick to. And these are given in more detail in the paper as well. We want to strive for comprehensiveness, so listing all of our outcomes, all of our strategies, all of our potential determinants. We want to indicate key conceptual relationships between those different variables. And you'll see that I typically use superscripts because color coding and arrows tend to get quite busy and difficult when there's lots of relationships that are trying to be portrayed within an IRLM. And then when it's appropriate, specify critical study design elements like the primary versus secondary outcomes, the independent variables versus those that independent variable strategies versus those strategies that might have already been present in the system and are not really part of the hypothesized effect of this particular study. So here's an example where we did an IRLM for pediatric hypertension guideline implementation in primary care settings. So we first specified all the pieces of the clinical practice guideline for pediatric hypertension. We then worked with our community stakeholders to rate the implementation barriers and facilitators within pediatric primary care practices, and again, used the CFR dimensions and domains here. We then worked with stakeholders to identify what would be the implementation strategies necessary to both implement the clinical practice guidelines and to address the implementation barriers and facilitators. You can see here too that this is where we started to do our superscripting, where the implementation strategies are sort of the anchor, and we go backwards to assign which of these implementation or which of these barriers are being are conceptually related to each of the individual implementation strategies. And you can see that this is never or very rarely an actual one-to-one relationship. Most of the time, an implementation strategy is going to be addressing multiple barriers, and also you're going to need potentially multiple strategies to address one barrier. So keep that in mind as you're going through and being as comprehensive as possible. Now, the auspice of this particular study was this is the part of the project process that we were focused on. It was trying to have stakeholder-driven selection of implementation strategies. So this is kind of where most of our work with stakeholders was. However, for purposes of comprehensiveness and getting a full picture of what would be happening, we proposed mechanisms that were also driven by our stakeholders. as well as identified our primary implementation service and clinical patient outcomes. Because we were focused mostly on the barriers, facilitators, and strategy selection, you can see that we only did our superscript relationships here. When this project is actually funded and a full trial can happen, we will fill out the full conceptual relationships between the studies. The other thing that was kind of unique about this, and this gets into study design, is that we had a tiering process of prioritizing the implementation strategies that would be used sort of in an optimization process, where we started with all of our tier 1 strategies as a singular package. And then over the course of the study, we pulled up and drew from tier 2 first and then tier 3 strategies. And the logic model will be really helpful in understanding which of those potential strategies, additions in particular, that we can draw from to address barriers that haven't been effectively overcome by the first set of strategies. And this paper is published in Implementation Science Communications. So in terms of scale up, this is really, again, an extension of the IRLM. So what is scale up? So here's a little terminology to get us all on the same page. So scale up addresses the system and infrastructure issues that arise during a full scale implementation. So it's taking a slightly larger picture compared to what we typically do with an implementation research project, which is really focused on kind of a small number of implementation sites or implementing systems. This really starts to think about, if this were to be done on a really large, wide scale implementation, what are the system and infrastructure issues that may arise? So adoption and replication of the intervention within similar systems, that is where it's already been tested and shown to be effective, is kind of the definition of scale up. And in most situations, this is done with little modification, but I think we're understanding that modification, adaptation really is kind of more the norm than it is the exception. So I put that in parentheses to demonstrate that. So the main 3 components of scaling up are to use a clear sequence of activities that are needed to take the intervention to scale, also to articulate the context and environmental factors that will foster scale up of best practices. So contextual and environmental factors in our situation are really implementation determinants. And you also want to, in this case, describe the infrastructure that is required to support scale up. And this happens at kind of the lower level of the infrastructure within certain systems, but also potentially a larger infrastructure that's needed at governmental agencies, local health departments, other kind of higher level potential infrastructure sources. Another kind of interesting thing that has to be done within most scale-up studies is to define the microsystem or mesosystem that can be replicated as the intervention is scaled up. And this is what's called the scalable unit. So in certain situations, an intervention can have uptake simply by engaging with a, let's say, a hospital system. In other situations, there needs to be multiple entities involved and higher levels, including government, potentially regulatory and policy agencies, and their oversight and the areas that they oversee and the breadth of that will indicate a larger scalable unit than one that, like I said, like a sort of single hospital can take up certain innovations. And then quality improvement and other implementation strategies are used to help progress towards full scale at each step in the scale-up sequence. So I would like to draw off of the Institute for Healthcare Improvement model, or the IHI model. So I'm not going to go through this in a lot of detail, other than to point out kind of the pieces of this that are relevant to using it for implementation research. So we start with typically a best practice. We have an idea that we need to scale up this best practice. There's always a situation of needing to set up or get ready for implementation. And so this is often just trying to understand the current state and develop an initial theory of how to scale this intervention or this evidence-based practice. And again, I mentioned we then build what we consider our scalable unit. And this starts with creating new change and developing a change package that is relevant to the size and scope of that scalable unit, as well as the multiple levels that are going to be part of it. We then actually test scale up. This usually occurs in kind of a small number of scalable units, really as a demonstration project. And then if that's successful, and we've been able to adapt and validate the change package, we can then start to go to full scale. And full scale is really replication and adaptation of that package to all relevant contexts. So in implementation research terminology, we might say that this is really kind of our process model. This is what we do as in research process to go through these different steps. The content that's involved at each step is really the activities and goals of each phase, so what you're trying to accomplish. These adoption mechanisms that are talked about in the IHI model, which involve things like communication, leadership engagement, evaluating and potentially improving social networks, et cetera. These are starting to get into the actual implementation strategies that are needed to target the hypothesized mechanisms. And then these support systems are really kind of contextual determinants as well as resources and infrastructure that can really help us go to full scale. This includes leveraging learning systems, using existing data systems to do kind of data monitoring, infrastructure for scale up that has to get implemented, or maybe it's already there and we can leverage it. And then also having human capacity for scale up, so the necessary expertise and just simply the necessary number of individuals. So we're really going to be focusing today mostly on the process of when you actually go to test, whether that's the testing of initial scale up or testing of going to full scale. So that's where the IRLM is going to be most useful. So in this case, we have all of our primary elements of the implementation research logic model. The only thing that I've changed here is that I talked about this implementation strategies as a change package, simply to align with the IHI model's terminology. So the things that are unique a bit about scale up is we have our best practice. So this could be the clinical intervention or health promotion intervention that was in previous IRLMs, but essentially this needs to be specified as well. We then have our scalable unit. So in this particular case, we want to identify what is the scalable unit that's needed for starting to test a scale-up approach. And then here, I've added the infrastructure and resources. And it is intentionally aligned with contextual determinants because there's a lot of overlap, both conceptually, but also just in practicality about what infrastructure and resources are needed, aligning with these contextual determinants. So I want to show an example, and I already see that my animations are messed up, but that's okay. So we start here with our best practice. And in this particular case, it's an intervention that I work with called the Family Checkup for Health, which is an assessment-driven, individually tailored, family-based obesity intervention for children ages 2 to 13 years. The potential scalable unit for the Family Checkup for Health are primary care practices within community health centers. And they're offered through a coordinated Family Checkup for Health service delivery model. So there are a number of resources of the Family Checkup for Health service that are aligned with expected primary care referral volume, and that has to be sort of determined. So how many different primary care practices do you need to actually have sufficient number of eligible and engageable families to be able to support a kind of centralized Family Checkup for Health service that takes referrals from multiple community health centers? We then have a number of infrastructure and resources that are necessary. So this could include things like BMI surveillance that's happening at well or sick child visits, automatic percentile scoring and alerts. And for the FCU for health service, we need to have skilled, diverse workforce, electronic assessment systems, and implementation training and coordination. We then have a number of contextual determinants, not necessary to go through these in detail. We then have an evidence-based change package that we have tested in prior smaller studies that involves things like engaging the CHC's leadership, having multiple both asynchronous and synchronous learning opportunities, ongoing data monitoring and feedback, as well as fidelity monitoring, to name a few. We then have a number of adoption mechanisms that we think are going to lead to this being adopted and sustained. It shouldn't be just simply getting people to adopt, but actually to deliver and sustain over time. And then we have our primary outcomes, and you can see aligning with scale up, the primary outcome is getting to adoption, and then secondarily to reach the majority of the population, to do so with fidelity, and to have implementation costs that are reasonable and potentially have return on investment, and then sustained practice. So there are a number of resources for using the IRLM that I want to point out. We have a quick reference guide that really gives definitions and terminology for folks to have as they're kind of learning the IRLM. And this is particularly good for users who are kind of new to implementation research and are kind of odd and esoteric terminology at times. So this can be a really helpful little quick guide to have with you. We also have more in-depth worksheets that go into determinants of implementation, implementation outcomes, as well as implementation strategies. And we've drawn again from existing taxonomies, frameworks, and other kind of glossaries, so that most of these things should be familiar and they also have existing resources of their own that users can then refer to if needed. The Center for Prevention Implementation Methodology also provides a website or hosts a website that has the majority of these resources, as well as some IRLM examples beyond the ones that I shared today. So thank you for coming today. I hope this was a useful talk, and I hope that folks see value in using the IRLM in designing and executing implementation scale-up projects. Thank you.